Miracle was starting on time. Happy Friday, everybody. Thrilled to see you all, and I'm sure more and more people will trickle in just the next few minutes. Today, I get the distinct pleasure of discussing with a friend and colleague who I've now known for many, many, many years. I feel like I've shared the story of how Mengyu and I first met in person many times before. This is not the first time we get to co-discuss, which I'm really, really excited to share. But when you have a legend in the space who continues to show up, and in fact, feel inclined to apologize when she can't, even though it's been years of sharing the space together. You're working with somebody special, and Mengyu, it's just really cool to continue to share this space with you. And I think this is hopefully a small peck in many future discussions. Excited for yet another one. I'll hand you the mic to say hello, and then maybe we can introduce everybody else who is making this happen.
Yeah, hello. Such an honor to be co-discussing with Ravi on Friday. I feel, yeah, speaking of the first time we met, I have a funny story to share. It's like the first time we met was actually after a night shift, and I went to one of Ravi's case conference. I believe he facilitates for the residents. So I was a little bit disoriented during that session. Was at noon, I think, which was similar to how I first met Dr. Gurpreet Taliwa, which was after like a long jet lag, where I was very disoriented, very sleep deprived during their sessions. So that's just remind me of this funny correlation. But yeah, uh, very excited for Sneha's case, and thank you so much, and also thank you, Julia, for scribing, and Glenn for doing the teaching points.
I'm so sorry, I froze. The San Francisco VA is not paying their internet bills, so I had to use my own hotspot. I'm bummed I missed that, Maggie, but I know it was nothing but love. I assume so. That was your chance to poo-poo all that all of our time together, but I know that didn't happen. Um, All right, shall we hand the mic to sorry, you already did that. I'm just pretending like I caught you at the end of your spiel. Um, but Julia, do you want to say hello?
Hello, everyone. Very excited for Snira second case, I guess, and for Ravi and Mengyu. Amazing discussion as always.
Nice to see you, Julia. And Glenn, mic to you.
Hello everyone. I'm excited to do the teaching points today. I just got another came from another learning from a rapid fire class with management and excited for more.
More and more learning. Another incentive to keep bringing your cases and present. Sneha, who is presenting today, I'll hand her the mic. One of our most recent Academy members did the same. Really encourage all of you to do so. Mic to you, Sneha.
Hi everyone, very excited for this case, right?
All right, shall we get going, y'all? All right, Sneha, take it away. Mengyu, I think we've discussed in the probably just go back and forth and alternate. Is that okay with you?
Sure.
Awesome. All righty. Good to kick it off, and then we can alternate thereafter. All right, Sneha, mic to you, my friend.
So I'm very excited for the case, and I've been waiting on this case for some time, and today I found the time. So to keep it as authentic as possible, so this was a chaotic OP day when it was already getting out of hand, and the sister outside informed me that there was a patient waiting in a wheelchair. So we prioritize patients on wheelchair for two reasons. One is quite easy to understand, where we expect them to be a little sick. Secondly, we need the wheelchairs for circulation. So for both these reasons, they inform us beforehand when somebody is waiting. So I immediately asked them to bring this patient in, and I was little surprised to see a young patient accompanied by his mother. So this was a 28-year-old male who came in a wheelchair, and he reported abdomen pain for more than 2 weeks with some giddiness. So I will stop here and we can reflect on this.
Yeah, wow, what a great setup. What an interesting setup for thank you for the background. So we have a young patient and surprisingly wheelchair bound. I think would be curious to know if this is his baseline or is this something new that happened in the setting of this 2 week illness. And then he came in with abdominal pain with giddiness, which I translate into like some dizziness, right? Like some lightheadedness or like some sort of dizziness or maybe weakness, weakness. Please correct me if I'm wrong. So yeah, I think then the localizing symptom we have for now is the abdominal pain. Of course, we always think about can misdiagnosis, usually more happen in the setting of acute or hyperacute onset, like the like we see in the vipomnemonic. So we can certainly clarify, see if there's any acute component that brought him in. But so we would certainly consider all these like vascular perforation, obstruction, and also inflammation, which can go a little bit longer in terms of time course. But I think subacute abdominal pains is kind of interesting. Um, I think there's like different ways to approach. We can use anatomical to see whether it's diffuse, which points to our certain etiologies like the bowel, or is it more localizing to help us localize to a certain organ? And then if there's any modifying features like postprandial or an empty stomach or like what positional change to kind of help us make progress. I think the patient will and then associated symptoms like in terms of dysfunction, like weight loss. I think wheelchair bound is not a good sign. Maybe it's already a sign of dysfunction here. Maybe there's some electrolyte disturbance secondary to that, or even worse, associations causing the dysfunction. Uh, I think he will by himself at CT abdomen pelvis with IV contrast, as happens in the ED, in the usual ED setting. Not sure about the resource in the ED, but I think here in the US would certainly get that. Um, yeah, I guess I'll pause here and ask Ravi for his thoughts.
I feel so in uh, yeah, I feel like the authenticity of the presentation here is a marker of somebody who's seeing a lot of patients, and only when you're seeing as many patients as Sneha is seeing, do you really are you able to capture the weight in the room and also know when to pause. And I think Sneha, this is a real. This is why I think we push people to try to present. It allows you to really take your skills as a clinician to the next level. For me, I have nothing to add to your thoughts, Mengyu. And for me, the tension in the room is the paradox. What I expect somebody to have with abdominal pain is an emesis bag, not a wheelchair. And so I think instead of the assistive tech tool that the patient is using does not necessarily address the problem they're having, i.e., the wheelchair does not map onto the abdominal pain. And so for me, that creates two completely independent problems. The question is, where does the giddiness fall in? Is the giddiness a part of a neurological sphere, in which case the wheelchair fits into that space very well? Or does the giddiness more suggest a cardiovascular issue, which may be a marker of the severity of the abdominal pain and vomiting potentially? But you have a disconnect, and I think you need to separate those two things out rather than assume that the wheelchair is supporting a patient with the abdominal pain. That is not usually the case. Usually you have a blue, in my case, emesis bag. And so I'm really curious to see how these two observations interact with each other. All right, so yeah, Mike, to you.
So I was taken aback by this disconnect as well because the patient was more concerned about the abdomen pain and I was more concerned about the wheelchair. Anyway, so going on to the history of present illness, 3 days prior to this presentation, he had visited the emergency department with abdomen pain for about 2 weeks, and he had been treated with started on PPIs and sent home. 2 weeks prior to that presentation, he had a bilateral knee pain and swelling of both feet, for which he had been treated with NSAIDs. He also has shortness of breath and giddiness for 5 months, an episode of syncope 3 months back, epigastric pain intermittently for the last 5 months. He had this bilateral knee pain for 2 weeks, as mentioned earlier. His review of systems, he had no visual symptom, he had no oral or genital sore, he had no skin issue, he had no joint pain except for the both knee pain that he had reported. He had no chest pain, palpitation, he had no cough, no nausea, no urinary symptom. He did have frequent semi-solid stools for the last few weeks. He also has had a weight loss of 4 to 5 kgs the last 6 months. His past medical history did not reveal anything significant, and his family history was non-contributory. So, going into his social history, I learned that he was an IT professional, but he has not been working for the last 6 months. He denied any health-related behavior. So I will pass here so we can discuss.
Yes, Neha, I think this is a really powerful set of data, and I think the upgrade that we have is this is no longer a syndrome that appears to be localized in the abdomen, but actually there's features in the chest, with shortness of breath being the most prominent one. And there also seems to be existence of this disease in the extremities. Um, and I think each of these things needs to be clarified further to be able to make progress. Clarity on what organ specifically in the chest or the abdomen is being implicated, then clarity on what part of the extremity. The latter seems to be an articular issue with the patient having difficulty bearing weight, but that it has to be confirmed on exam. So I think you're in a situation where you're much more invested in trying to define the problem than really starting to solve it. The curious thing is interfacing all this with the time course and what we label the time course as. Clearly, we understand that as an IT worker, he has to be decently functional. And the question is, when did he start to lose his function? And is his function being lost 6 months ago or more and more recently? And I'd really be curious why he quit his job and why he could no longer do that. But the truth is, we seem to have a multi-system disease process. And a very simple way of invoking a multi-system disease process is to ask, is it a structural issue or a substance? And so, of course, there's going to be some organs that are dysfunctional, yet to be determined. But are they dysfunctional because there's a structural compromise of those organs, or there's a diffuse bathing in the blood of a substance that's causing all these things to go offline? So, a lot of work to be done. I think the major next steps are to find more precise labels than a chest problem, shortness of breath, belly problem, abdominal pain, and a extremity problem, knee pain, and turn those into more specific labels. What are you thinking, Mengyu?
Yeah, I would agree with you, of course. I think it's the knee pain is a little bit surprising. And yeah, as you said, could suggest a multi-organ process. And I think the swelling of the feet could help because we always have a very robust approach to swelling, and we look up first if it's yeah, it looks like it's both feet. So we look up into the organs, heart, liver, lung. Sorry, heart, liver, kidney. So we will use that to kind of make progress to see where we land and then see how that fit into the disease. I'm really really impressed at how rich this aliquot is in terms of the system is involved. I think two just like pattern recognition, like two things came to mind, but I also don't want to overfit and or commit without more information. Like so, IgA nephropathy and IBD are the two things that come to mind. We want to link the abdominal symptoms and joint pain. But I do agree we need to at least start a workup for short of breath, workup for swelling, and then look into the abdominal pain with yeah, I think that too kind of see how where things uh, see how we can make progress. I think it's helpful to know there's no skin like petechiae at this time, but we can also see how things evolve.
So, yeah, great discussion. So I will go on to the next aliquot. On general examination, he appeared ill, slightly emaciated, and I surmised that it was generalized weakness, basically why he was in a wheelchair. And he had no icterus, no discernible edema on examination. BP was 90 over 70. Pulse rate was 106 regular. Respiratory rate was 24. Saturation was 97% in room air. Cardiovascular examination revealed a normal S1, a loud S2 with a loud P2 component. And he had a parasternal heave. Examination of the respiratory and the central nervous system was normal. In examination of his joints, he had I did not find any swelling or tenderness, not even in the knees. So we'll stop here. So we'll discuss.
Oh wow, yeah. This patient definitely looks very sick, like subacutely sick, and I think there's some concern for probably some hypovolemia based on the blood pressure. Even though the map is okay, I think the systolic is pretty low and it's on the lower end, so which is probably part of this illness and the diarrhea, abdominal process, um, and the weight loss, nutrition loss. I'm a little curious about the loud P2 and peristernal heave because that makes me, I think I translate that into um, could be RV RV enlargement or RV hypertrophy or like a maybe pulmonary hypertension, which can cause loud P2. Mm. And then I was trying to think how that would be linked to, could be fit into part of the systemic process. Um, Maybe there's a, so because if I think about RV failure, I would think of pericardial effusion or other than pulmonary hypertension. I think MI is less like in a young patient. We don't hear like a heart, chest pain history. I think with the process going on, I think more like, but if there's pericardial effusion, you hear some decreased. There could be other findings, but we don't see like GVD. Um, and there are certain conditions that can cause pulmonary hypertension. I think 2 weeks is a little acute for that, like certain parasitic infections. So I'll maybe have to put a pin and think about it more. Hmm. And there's no joint swelling or tenderness, like subjective finding. So it's more like a arthralgia, not an actual joint, like a synovitis that we can tap and do studies on, which makes me more think it's a part of systemic process rather than like a localized septic joint or infectious or um, uh, yeah. So yeah, I'm gonna have to pause and see what progress Ravi can make, and please help out.
Yeah, I think maybe it's hard to imagine when somebody's been sick for 6 months that you see these vital signs. Most people who are sick for 6 months have been tolerating illness for 6 months, presumably 6 months, maybe less. So their vitals are usually normal. There's nothing vitally sick about a 6-month illness. But when you see this, the patient has hemodynamic compromise. The blood pressure isn't an error because the patient is tachycardic. And sometimes we overcomplicate how we teach hemodynamic compromise. The hemodynamic system has two components to it, the heart and the vessels. And the very simple thing that you're trying to figure out is the cause of the hemodynamic compromise the heart or the vessels? Before I illustrate what that means, I'll give you examples. Hemorrhage, vessels. Hypovolemia, vessels. Sepsis, vessels. Anaphylaxis, vessels. This is not a vessel issue. How do you know? There is a blockage in the heart. How do you know there's a blockage in the heart? Whenever there's a blockage in the heart, downstream of that blockage is low pressure, here measured by the blood pressure cuff. Upstream of that blockage is high pressure, here auscultated by the very, very astute Sneha. Super loud P2. You hear kaboom in her stethoscope, and you hear nothing of the same magnitude in the arterial blood pressure cuff. Very soft sounds in the radial or brachial artery and very loud sounds in the stethoscope. This is a heart issue. And it's a reminder that when you're trying to solve a systemic problem, you have two options. Either the disease is fundamentally widespread, or it is widespread by definition because it exists in the system that is found everywhere, cardiovascular system. So I think you quickly reframe this case as very likely having pulmonary hypertension. Question is why? But also the other question is how bad? And as soon as you hear a parasternal heave, that tells you that the pulmonary hypertension is bad enough that the RV now is having to squeeze every single time it moves. Every time. No break. You know who else has a parasternal heave? Me on my 5-mile run this morning. But now I don't. But this poor person is doing that all the time. And so I think the question becomes, what are the other features of this disease in addition to his likely pulmonary hypertension? Are they clues to the underlying cause? Or are they simply mechanical complications of a backflow into the belly causing abdominal pain and into the legs causing leg issues? And that I think is going to be really, really crucial. I cannot wait to see this person's EKG. I think that'll be very, very illuminating. But we've now taken the shortness of breath and we know what it is. It's likely pulmonary hypertension. We know that pulmonary hypertension is advanced based on the parasternal heave. And the question is, what is up with the belly and what is up with the legs? And we still have to figure out what type of pulmonary hypertension this is. Young, otherwise healthy people often break the rule. The rule is that in all comers with pulmonary hypertension, the issue is on the left side of the heart or in the lungs. But in young, otherwise healthy people, that's not true. Class 1 or pulmonary arterial hypertension starts to compete with those two things. And so I'm pretty worried about this patient, as is Mengyu, and I think we have a lot of progress to make, but we've definitely made huge, huge progress. And I want to just take a moment to emphasize to you all what just happened in real life. Sneha took this person who's been suffering for 6 months, who's been given NSAIDs, been given PPIs, been given all this stuff. And with the power of her stethoscope, she has probably rescued him from continued diagnostic errors. So whatever happens in this case now, I think everyone should realize what you've just done for this person. You finally picked up something that truthfully was there for the taking probably quite a while ago. It has snuck under many people's radar before, but I kudos to you for catching it. It changes the complexion of this case entirely. All right, Mike to you.
Exciting discussion. So I will reveal the labs now. His hematology revealed blood hemoglobin of 10.1, a total count of 3,400 cells with a normal differential count. His platelet was 81,000.81 lakhs. We did a peripheral smear which revealed pancytopenia with no atypical cells. His blood chemistry revealed a BUN of 10, creatinine of 1.01, sodium of 137, potassium of 4.06. This calcium was 7.7 and albumin was 2.8. The albumin adjusted calcium would come to 8.7. It's normal. Urine protein examination revealed 1 plus protein. Well, we quantified the proteinuria and it was normal actually. Urine PCR revealed a 0.18 ratio. ECG showed a right bundle branch block with ST depression in leads 3, AVF, and V2 to V4. A troponin I was done, which was 27.5. Our lab cutoff was is less than 17, just over the limit. The BNP was more than 700, and this is way above the normal range for a. This is an ER panel, so 100 is the cutoff for the BNP. So we did the D dimer, which was 221 and normal. Echocardiography revealed RA and RV to be dilated, the RVSP of 73 mmHg, moderate to severe tricuspid regurgitation. He had a good biventricular function with left ventricular ejection fraction of 62%. This uric acid level was 7.4, which was the normal is less than 7.2. Chikungunya RT-PCR was negative. Rheumatoid factor was negative. Anti-CCP was negative. Considering the pulmonary hypertension, we proceeded with the autoimmune panel. ANA was 2 plus positive. Anti-PR3 was positive. Anti-MPO was negative. Anti-SNRNP was positive. The other anti-SM, SSA, anti-Rho, SEL70, anti-Jo1, histone, including the dsDNA, were all negative. We did an ACE level, which was 50 and normal. The C3 of 100.4, C4 of 21.2, both of which were normal. He had a CRP of 11 and an ESR of 24. We did a thyroid profile, which were normal with free T4 of 1.19 and a TSH of 2.73. An ultrasound abdomen was done, which revealed a hepatomegaly with gallbladder wall edema, bilateral thin pleural effusions, and minimal ascites. So I'll stop here.
Oh, wow. I don't even know where to begin. This is such an incredible case, and I think, Snehal, you've really pushed the case along. I think, Mengyu, maybe I can continue to pick up on the pulmonary hypertension theme just to reinforce that, and then I'll leave everything else for you to discuss. And I think the pulmonary hypertension theme is much more elucidated on the imaging section rather than the lab section. The first thing you probably received in real life is the EKG, and the right bundle branch block shows the consequences on the RV of the pulmonary hypertension. And the same can be said of the ST depressions in all the leads that map onto the RV, the inferior leads and the anterior precordial leads. So this is a really suggestive EKG of RV strain. Um, and RV strain is essentially a consequence of pressure overload on the right ventricle, as another hint to the presence of pulmonary hypertension. Um, RV strain is a pressure overload phenomenon, and you can see on the echo the consequences of that pressure overload as the right atrium and right ventricle dilate. The dilation is an adaptive mechanism to offload that extra pressure, as is thickening, which I suspect was also seen. The echo, by assessing the severity of the tricuspid regurgitation, gives you an estimate of the RV systolic pressure, and it is extremely high, confirming the diagnosis of pulmonary hypertension. What you now do is try to figure out, okay, I know the pulmonary artery pressure is high. Is it because there's a problem intrinsic to the pulmonary artery, or is it a problem downstream that's causing a blockage in the pulmonary arteries? And so you query the pulmonary capillaries that are in the lungs by CT scan or X-ray. And here we don't have robust data of that, but the patient doesn't have any exam findings to suggest a pulmonary localization. You then query the left side of the heart and wonder, is the left side of the heart radiating into the pulmonary artery as a consequence of mitral stenosis or reduced left ventricular ejection fraction? And this answer so far appears to be no. So you're only left with the idea that the working hypothesis is now that the disease is in the pulmonary artery itself, which begets the question, is it a microscopic pulmonary artery disease, which would be called class 1, or is it a macroscopic pulmonary artery disease, which would be called class 4? The distinction between those two is class 1 is a CT negative diagnosis, and class 4, you see a bunch of things on CT, including thrombi inside the vessels, which would be the leading example. So the localization exercise makes a pulmonary and a left-sided cause of pulmonary hypertension less likely. And the remaining question is, this is a micro or macroscopic cause of those pulmonary arteries. Another thing to emphasize the localization is when you look at the ultrasound of the abdomen, you see that there is significant congestion in the liver and the gallbladder and ascites. Patients with class 1 pulmonary hypertension tend to have a disproportionate amount of fluid backing up in their abdomen over their legs. The physiology of that is beautiful. I'd encourage you to read about it. I think it probably can't be captured in a short case-based session. So both the venous consequences in the abdomen and the lack of pulmonary and left-sided cardiac findings make this very likely to be a class 1 or class 4, which is what is called precapillary pulmonary hypertension. But we have a lot of other things to study about why that is happening. And for that, I'll hand the mic to Mengyu.
Yeah, what a masterclass on pulmonary hypertension. Thank you, Rabih, for setting this up for for my discussion. Yeah, I think in addition to this finding, I think this we have pancytopenia, for which we often use the 4S approach, and here we are dealing with a subacute course of pancytopenia. I don't think it looks like an acute, hectic process. It's more like a subacute, which we can think about a uh, space occupying process like a granulomatous disease or like myelopathisis or a stem cell issue. But I think we don't see a typical cells, at least in the smear. So that gives us however, I think another possibilities among the systemic causes splenomegaly. I wonder if there's underlying splenomegaly which could explain pancytopenia, since we see the liver is really affected by the likely affected by the pulmonary hypertension. Um, then we have the clue of the autoimmune antibodies. So I will put aside the NTPR3, which is the ANCA, but I don't see other features of ANCA vasculitis. So it could be part of the, however, so I'll put that aside for now. Unless the kidney, I think I'm seeing 1 plus protein, and I forgot what the urine protein creatinine ratio, but I don't see any hematuria. Please correct me if I'm wrong. But I was more caught attention by the anti-SNRNP. I assume that's the same as the anti-U1 RNP, right? Like the instead of the small. Yeah, if it's an anti-U1 RNP positive and an ANA, especially if they're strongly positive, then I'll think about MCTD, which could be associated with pulmonary hypertension, group 1. Sometimes you often have a renal phenomenon in your hands concomitantly. I was told by my attending in my medical school, like the renal phenomenon is the pulmonary hypertension uh, of the fingers. Oh, sorry, pulmonary hypertension is the renal phenomenon of the pulmonary vessels. Anyway, so that makes me think about that link here. But I would be curious where this patient is from geographically to see if there's other. I think we should do the full workup for pulmonary hypertension, especially group 1. So we would send HIV. We would interrogate the possibility of schistosomiasis, which can cause both group 1 and group 4 as a like precapillary causes. And part of me also wonder if it could be like a liver disease causing secondary group 1, but I think that may be less likely. It seems the other way is more common. Um, and trying to see how, yeah, scleroderma antibodies negative, so that's helpful. How to make progress from here? I think the patient will need a right heart cath to further clarify the pulmonary hypertension and look for systemic. I'm still having like some concern about infectious causes that I think we should rule out, but otherwise think about whether it's an autoimmune cause of this pulmonary hypertension. Yeah. Oh, and the pancytopenia, I think deserves some workup. For example, at least rule out hemolysis and then look at the spleen. And considering granulomatous process, yeah, based on the patient's exposure, I'll maybe go back and ask the patient's exposure. I think I would imagine a lot of actually granulomatous disease can be associated with pulmonary hypertension. Actually, for example, sarcoidosis, many of them cause group 5, like sarcoidosis can cause group 5. There could be some hemolytic anemia process causing group 5 as well. Or like, but I would complete the pulmonary hypertension workup, including a CTA imaging and a VQ scan to see to help make further progress there. But potentially, if there's no splenomegaly, then I would think harder about the granulomatous process and maybe a bone marrow biopsy to help clarify on that. I guess I'll stop rambling now. Robbie, what else? Please add.
Oh, there's nothing left to add, my friend. I think you're telling us that essentially there's an juicy overlap between the two, but your workup is pushing each problem independently, right? I think not many people with pancytopenia have pulmonary hypertension, and not many people with pulmonary hypertension have pancytopenia. So it might be a interesting case where somebody has a cool disease that has both. But in the judicious solving of this problem, we require you to keep those two things separately and then see if the causes overlap or they may be completely different. We'll find out. All right, yeah, Mike, to you.
Great thoughts, actually. And I wish I had all this in my head when I was seeing this patient, but this was 1 year back. So just starting out seeing OP patients. So anyway, so we did a CT pulmonary angiography, and this is a short aliquot. And the CT pulmonary angiography showed cardiomegaly with features of pulmonary hypertension, small pericardial effusion, diffuse ground glass attenuation, and small alveolar densities in both lungs, which could possibly be congestive or an infective process. So this is a short aliquot, and then the final aliquot reveals a diagnosis or our consensus for the case.
Oh wow. Uh, do we do breakout rooms on Fridays?
Yes, I was just gonna suggest that. I was so glad you did. Yeah. Mengyu, I think that I sense that your very experienced mind is having trouble putting this case together, and the truth is that that is a universal phenomenon. Maybe before we go to breakout rooms, I'm really curious how you're sort of summarizing this problem for the benefit of everybody, and so that they know exactly how an experienced person is at least crystallizing the issue, and then maybe folks can start to think about it and we can come back in a few minutes. Does that sound okay?
Sure, yeah. So this young gentleman has, I think the crux of the problem is a pulmonary hypertension, like based that can explain a lot of his symptoms and based on. So we have to solve the pulmonary hypertension, and so far we've made progress that we didn't think it was a group 2, based on the normal LV function, and uh, we CTA also didn't show P, I assume, so there's no macro um, pre-capillary. Um, and then the CT, I'll be curious about the lung. Here we have some finding of a lung pulmonary disease, which, you know, I think earlier I think that is still a possibility, but we don't have like the classic history of like, for example, chronic lung disease. Uh, the only, yeah. So we are still thinking about group one. However, when you see group one and diffuse GGOs, like that make me think about one condition, which is PVOD, which can happen in young patients. Um, but I wonder if the diffuse ground glass uh, uh, opacities are, if not that, then wonder if it's part of the systemic process, like for example, granulomatous inflammation that's causing both the lung infiltrates and the pulmonary artery hypertension, or I would be hard to imagine that is the cause of like that is causing group three pulmonary hypertension. So I think I would maybe try to explain it separately, like still thinking about group one and then thinking about what can cause the GGOs. Mm.
Yeah, I think you're setting up the tension very well. This person has one thing we know for sure they have, which is they have pulmonary hypertension. And I think the question for everybody to discuss is how does the GGOs in the lungs influence the calculus? And of course, how does the pancytopenia influence the calculus? These are things we have to explain. Everything else is an additional clue, the ANA, the SNP, the EKGs. I think the melting pot really is pulmonary hypertension as the incontrovertible feature. And then the heavyweights are the GGOs and the pancytopenia. And then everything else is small decoration. So let's see how many ways we can put all these things together in breakout rooms, and then we will come back in about 5 minutes or so and reconvene. See you all soon. Alrighty. Mengyu, so you mixed your thoughts with other people. What did you all come up with?
Yeah, I had a nice chat with Daniel, who's joining from South California. Welcome.
Alright.
Um, yeah, so first I thought about PVOD, which can cause class one pulmonary hypertension features with GGOs, like some features of group three, because it's like a tricky trap that I presented a case in the past. Uh, but I wouldn't
Yeah,
imagine, but normally you would see some lymphadenopathy, but also I wouldn't think it would cause pancytopenia. So I feel like that is not explained by that. So then I think if I have to explain things separately, so then I kind of think through what else could cause group one pulmonary hypertension and layer that onto the cause of GGOs or um, uh, pancytopenia. I still think about some. So first, I want to do like basic, like simple things, like I want to check HIV, like vitamin B12, vitamin C, like or look for that to like like
right.
simple things that can explain both, but also um, still wondering about. I'm still curious if there's splenomegaly to explain the pancytopenia, but that still the GGOs is not explained. So wonder about uh, among the uh, causes of subacute pancytopenia. Uh, is there like a granulomatous disease causing the lung infiltrates and the uh, like I think for many of the autoimmune process, including like sarcoidosis, which and then if we think about autoimmune feature, like I still want to rule out any underlying easily treatable disease or infections before I commit to
Right.
calling that because then before you if you need to treat with steroids or immunosuppressants, um, so a part of me wonder if there's like schistosomiasis or um,
Yeah.
that is like one thing. There's other like rare conditions like Gaucher's disease, which can cause both pulmonary hypertension and pancytopenia due to the subspace occupying process. And I don't know if the knee pain can be folded into that. It's probably too rare to be true. Um, yeah.
Yeah, I think it's been such a struggle to find the cause of pancytopenia, right? I think ask yourself, you imaged the belly, you looked very well at the chest, and you don't see anything that accounts for it. So it makes the space occupying causes a little bit less likely. And the pancytopenia isn't subtle. And I think whenever you might even ask yourself, what causes pancytopenia out of proportion? You can't seem to find anything. And I think that's often because it's either a substance like B12 deficiency or scurvy, but often the most kind of weird, unusual cause of out of the blue pancytopenia that's deep and pronounced is lupus. And so I asked myself uh, the question of pancytopenia plus pulmonary hypertension, what reflex that triggers? And I think that's every patient with lupus, right? And so what is the roadblock to that diagnosis in this patient? I think, of course, naturally the gender, but also naturally looking for an alternate explanation. I think you looked hard and hard and hard, and every other hypothesis has some friction with it. And the question becomes, what does those GGOs really represent? And I think as a general rule of thumb, GGOs only represent one of three things commonly. Just it's blood or diffuse alveolar hemorrhage. Two, it's water, pulmonary edema. Or three, it's very gentle, mild inflammation from connective tissue ILD. Could this person have pulmonary edema? Very possibly. Um, could this person have diffuse alveolar hemorrhage? Very possibly. But I think the CT findings for me are yet another clue to the possibility of autoimmunity beyond the pancytopenia, and that this patient has possibly CT-ILD in the form of NSIP or organizing pneumonia. So I think I would be most worried about him having either mixed connective tissue disease uh, because of the RNP positivity or lupus. But I think given how sick he is, asking myself, have we crossed the threshold for treatment? And I think we've certainly crossed the threshold for treatment of his pulmonary hypertension with medications to reverse the vascular phenomenon. But I think the distance to immunosuppressing him would likely be much easier if he were a more typical demographic, i.e., the female to male ratio were reversed. And I think, is that really the only roadblock I have? And honestly, when I say young person, and I omit the gender for a moment, who has advanced pulmonary hypertension and pancytopenia and no clear alternate cause, I can't say the diagnostic threshold is met definitively, but the therapeutic threshold to try to reverse this process is very close. And it would be very ironic if after missing yesterday's diagnosis of lupus, today we overcall it. It would be called some kind of made up bias that doesn't matter. Uh, but that's my calculus, Mengyu. How does that
Yeah,
sound?
amazing. Now that you said that, I think, yeah, it really fits lupus with the pancytopenia and everything. And I think it's really funny because on Tuesday, we had a CTD ILD case,
Yes, I
and then
know.
yesterday we had a lupus, and now today it's like such a good learning this week on this theme. I think I was probably maybe primed to think too hard about things that I really want to rule out before I commit this
Yeah,
patient to
100%.
autoimmune treatment. But
Yeah.
taking a step back, it does fit quite well with lupus. Yeah.
Well, we'll see. Sneha has the ultimate card. Mike, to you, Sneha, what do you have in store for us next?
So, you were actually quite right in that not that this lupus, that the evaluation was actually not complete. The reason being, we have not done an HIV test for this patient. Um, the reason that it was not done early, and probably you would have done it quite early on and do not have had this many confusions at all. But the thing is, in India, it is a little difficult to convince a patient to get an HIV test. It's a lot of times socially damaging also. And a lot of times we lose the patient itself. They do just go away even when we are exploring the possibility. So finally, we did an HIV test, and HIV was positive by two ELISAs and one Western blot. There were some doubts about the HIV because certain times there are case reports of there being a cross reactivity when an ANA or a RNP antibody is positive. We did a viral load also, and it was remarkably elevated with 3 lakh and 21,000 copies. And here is here CD4 count of 75.
Hmm.
We found it little difficult to hang our hats on the autoimmune hypothesis, mainly because externally we did not find any other evidence of an autoimmune process except for some joint pain which was there before. And yeah, if not for the HIV, we would have probably gone that way. It still kept it in our mind, but then, to be followed up. I find this to be a problem in our thinking process because all these other factors come
Yeah.
into play in our
Right.
yeah.
Yeah, I'll just share my reflections real quick, Maggie, if you don't mind, because I have to go to rounds in just a couple of minutes. But yeah, I think Sneha, you're teaching us such an important lesson and about the stigma and the unfortunate consequences related to diagnosing HIV. I also think that if you rewind back the discussion to where you saw Mengyu being very strategic about her workup and mentioned HIV at least twice, if not more. And I think whenever you're solving such a complicated problem, it's such a good idea to avoid trying to link them and just be systematic in your approach. And every patient with pulmonary hypertension should get an HIV test, though I think Sneha is teaching us the difficulties of doing so. And maybe you can rewind the clock to yesterday's discussion about why we need to have a very, very high threshold to diagnose autoimmune diseases. I won't belabor the point, but I think Sneha, you're making that point with so powerfully with this case today. Autoimmune diseases are lifelong diseases, um, and if you're going to commit somebody to immunosuppression for the rest of their life, you have to be 1,000,000,000% sure that they don't have an infection or a cancer. And yeah, I think Meng, I remember the feeling that I had when you said you were rambling. I wanted to uh, share my opinion that you weren't, but I suspected that that maybe the rest of this case might do a better job emphasizing that you weren't rambling, but rather being thorough. And I think being thorough is really important when you have such a complicated problem. But big, big gratitude to you both for such an incredible hour of a lot of bread and butter learning along the way, how to think about how to think about pulmonary hypertension, how to think about pancytopenia, and then such a powerful lesson, especially at the end. Sneha, you've, I think, given everybody a little bit of a jolt as to how this evolved, and I think jolts like this are really, really important for all of us. So really, really appreciate you. Mengyu, I'll shoot you a message later to reflect with you. This is a real, real treat, and I'll be thinking about you guys on rounds. I'll be a little distracted by this case, and I'll try to, to focus on my actual patients now. Mengyu, I'll make you the host just for the end, if that's okay. All right,
Yeah.
thank you.
Thank you so much, Ravi. And yeah, thank you so much, Sneha, for such an incredible case. I have so much to read. I know HIV can cause pulmonary hypertension, but never actually seen a case like having such prominent features and also the systemic symptoms. I'm curious if the patient got better with the treatment for HIV. Um, yeah, do you have other reflections from you, Sneha?
So yeah, we did it as a part of an evaluation. We don't see that many cases of HIV in our place. We're not used to treating HIV patients, but his case was little difficult for me emotionally as well because though he denied any health related behaviors afterwards we got to know that he was also had a he was gay and he had been using IV drugs and all that, but he was a very gentle and a very nice human being, and these things happen in places like ours when the society is not very much accepting of everybody. and he had a very dictatorial father, and I spent a lot of time convincing the mother to take care of him, keep the other things aside and take care of him per se. The unfortunate, yeah, though I, I literally pleaded with the family because we had made the diagnosis for them to take it forth and have a regular follow up and all that, but they didn't come for follow up. And about a month later, month or two later, he actually had not been taken care of at all, and he presented with hemoptysis, large hemoptysis, and yeah, he had probably PCP pneumonia, but we could not it was beyond our capacity to handle. So we had to stabilize him and shift him to a different center. And he didn't make it.
Oh, that's heartbreaking. I'm so sorry to hear that. Words fail to describe how much gratitude I have for you to present this case to us and for the patient to allow us to learn from his experience, but also really sad that we could, not turn around for him, even though we made the diagnosis. But really, really appreciative for us to learn, allowing us to learn from this case. Thank you, Sneha. Yeah, I had a lot to reflect. But at this time, maybe I'll pass the mic to Glenn. Glenn, I saw your amazing teaching points. Please take it away, my friend.
Thank you, Ming, for the opportunity. Really learned a lot from this case, and thank you, Sneha, for sharing it with us. So we had a 28-year-old male presented with abdominal pain and dizziness for 2 weeks. So, like Ming mentioned, we wanted to rule out life-threatening causes of abdominal pain with the obstruction, vascular causes, perforation, and all that. And in the subacute nature of the pain, um, just wanted to know more about the pain. And for the dizziness, we thought maybe it could be related to the him being on a wheelchair, so neurologically, or goes with the abdominal pain, showing how severe it is. And then onto the HPI, we learned that patient had a knee pain and swelling of both feet, so thought multiple system could be involved here. And then on exam, found loud P2 and parasternal heave, which loud P2 points to pulmonary hypertension and parasternal heave points to right ventricular hypertrophy, of which we can connect it to the fact that pulmonary hypertension can eventually cause right ventricular hypertrophy. And because this patient is a young patient, I would expect mostly to be a type 1 um, pulmonary hypertension, since type 2 will be left ventricular dysfunction, which is less likely, and type 3, we didn't have any evidence of chronic lung disease. Then Ravi taught us about the concept that the patient has a hemodynamic compromise in the situation. We try to divide, uh, we try to think of heart versus vessels problem. So for the vessels, thinking of hemorrhage, sepsis, anaphylaxis, but in this case, being unlikely because of the blockage. So think the evidence that being allowed P2, so wanted to progress with an EKG here to know whether the problems within the heart or the vessels. Then the EKG showed us right ventricular strain, so we still thought it could be type 1. And Mengyu that the causes HIV, histiocytosis, autoimmune, and Mengyu got the diagnosis here. So thanks to Mengyu for that. And we then talked about pancytopenia. I wanted to link the two, sort of speak occupation lesion or some bone marrow disease. I wanted to know more about the workout of hemolysis and others. And anti-SNRP, when it's positive, usually associated with pulmonary hypertension, like maybe mentioned, and sort of could have Reynolds phenomenon also. The diffuse glandulous opacities, here went to breakout rooms, learned from same that the autoimmune infections also can cause this. So thanks, Sam also thought of other infections like HIV, got the diagnosis right. We also in the breakout room thought of autoimmune disorders, ANCAs, which can also explain the pulmonary hypertension. Also, Mengyu added the Carnomatous disease, Gaucher's diseases, likely differentials also. And in the end, they did the HIV test, which came back positive and came to a diagnosis of newly diagnosed HIV. So thank you, everyone. Really learned a lot from this case.
Wow, thank you, Glenn. That's amazing. Thank you for walking us through this incredible journey again with your amazing teaching points. Thank you, and thank you, Julia, for scribing, and thank you again, Sneha, for this case. Wish you all have a wonderful day. See you later.